Hello, I'm Dr. Brook, a board-certified dentist in both the American and European veterinary dental colleges, as well as a fellow in the Academy of Veterinary Dentistry. This lecture will cover canine oral pathology, or pretty much everything that you're going to find in the mouth of a dog, except for gum disease, which is covered in its own lecture. Pretty much all the information out of this book, including the vast majority of these pictures, are courtesy of well, it's actually CRC Press now, but it was Manson. This is my first book that I put together, and it's still my favorite, actually. It's a really nice textbook. It's good for client education. It's available, on probably on Amazon, but also on our website, which is dogbeachvet.com. This and the other textbooks that we have. All right. We cannot talk about oral pathology in a dog without talking about normal occlusion or their quote-unquote bite. A normal bite, I'm going to get up the little laser pointer here. So a normal bite is what's called a scissors bite. A scissors bite is where the lower canine is equidistant between the upper canine and the upper third incisor. It's not closer to one another, it doesn't touch one another. Lower incisors are just behind upper incisors on that little flattened area called the cingulum. And then we have what's called a nice pinking shear effect, where the lower premolars interdigitate to the upper premolars. This is the normal bite for most breeds. Okay? This is what it looks like in a quote-unquote show Labrador or Doberman Pinscher. Lower canine behind third incisor in front of upper canine, lower incisors just behind uppers. Nice pinking shear effect. Remember what this dog looks like. I'll show him to you in a little bit as a puppy. There are 4 classes of malocclusion. We don't talk so much about class 4, but it's a combination of class 2 and 3. That's called a wry bite, where the jaw is like over to one side a little bit. But the 3 classes of malocclusion are, class 1 is where the front to back spacing is normal. Okay? So you've got the incisors where they're supposed to be, the canines interdigitating, except for a tooth or teeth out of position. So this is a class 1 malocclusion. It's called a dental or non-skeletal one. And that's because the jaw is the correct length. The reason that that's somewhat important is the fact that these may or may not be genetic. We do believe that most of them are, because we tend to see this in the longer nosed dogs, and the lance effect we tend to see in Shelties. So there is a genetic component to it, but this may not be genetic. Any skeletal, any undershot, overshot, that's gonna be genetic, plain and simple. So in this situation, you've got that normal front to back spacing, but this lower canine is, the layman's term is base narrow. Veterinary dentists would call it lingual versus mandibular canines. And so now you got this lower canine punching up into the palate here. Now, we're going to go through a couple themes in this lecture. The first theme, and the most important one, is that oral disease hurts. If you've ever been bitten by a puppy with these nice sharp puppy teeth, you know what this dog is going through every single time it bites down into its palate. It's like getting bit. Not only is it painful, these things are also infected. This is pus coming out of those teeth, those holes that are being punched into it. So here's the big takeaway. You can take it away right now. Dental disease hurts. Dental disease causes infection, but there's almost never any clinical signs. This dog's eating right through it. Dogs with broken teeth eat right through it. I hear it every day. Well, it doesn't hurt. He's eating. Well, it's one thing to hear it from a client. It's a whole nother thing to hear it from veterinarians. Stop it. These things, if it would hurt you, it hurts your dog, and it needs to be treated. The last problem with this base narrow situation is this lower canine is stuck in a rut. So a lot of these dogs will actually grow out, and they'll have what's called an independent growth surge. And the jaw is genetically programmed to be normal, but now it's stuck because of the development. So we need to relieve that adverse dental interlock, we call it, and allow the jaw to grow to its full genetic potential. If we do, there's a pretty darn good chance that this will grow out and be normal. But if we don't treat it, it won't. So how do we treat a traumatic malocclusion or a malocclusion that's holding back skeletal growth in a puppy? We pull the puppy teeth. Exactly. When? Now. Right now. Tomorrow, the next day. The sooner this comes out, the quicker they're out of pain, the quicker they're out of infection, but the more time it has to grow. So really you should be having your clients, when you do these well puppy exams, have them look at their dog's bite, you look at their dog's bite. If there's a problem, you should be getting these puppy teeth out now. Okay? Because if you don't do something, or if it doesn't correct, now you're going to end up with something that looks like this. Now we've got a base narrow or lingual occlused lower canine in the adult dentition. And now he's really punching up into his palate. And unfortunately, this particular dog, it's not unusual for us to have veterinarians go, oh, let's watch that. Let's monitor that. Dude, if you had a piece of glass in your foot, would you want that monitored? No, you'd want it taken care of. Now, so we need to treat this. And unfortunately, this dog, I mean, they went to their vet when they was about 8 months old and they discovered this. And the vet said, oh yeah, let's watch it. Well, eventually blood started coming out of his nose because this created an oral nasal fistula. Treat these guys, okay? So how do we treat a traumatic malocclusion in the adult dentition? Well, there's 3 big options. Number 1, move the tooth. Everybody's favorite subject, doggy braces. Number 2, remove or extract the tooth. Who likes taking out periodontally healthy lower canines? Not me. And then the last possibility is to remove the part of the tooth that's causing the problem. And we're going to talk about all of those. This particular situation is where I really like doing braces. This is what's called an inclined plane. It attaches to the upper canine. Some people make it out of acrylic. I generally use the cast metal one. It's stronger. It's dog proof. I like that. It has an expansion bar here so the dog can grow. And the client doesn't have to do anything. Every time the dog closes his mouth, it provides its own orthodontic force, slides it out to the side, the maxilla becomes a natural retainer. It works essentially every time. As long as you catch it early enough, it works out great. This is a really good option. So that's what I like to do. The other option would be to extract them, okay, or to lower them, but in this situation, it's much better to keep the tooth intact. Okay? Class 3 malocclusions is where the lower jaw is longer than the upper jaw. So now we've got these lower incisors out in front of these upper incisors, and we kind of lose that pinking shear effect sometimes, and we have our lower canine out here. So if there's no trauma, okay, so here's just a German Shepherd trying to be a bulldog. His lower canine's out in front of his upper lip. He's not causing any trauma. One important point though, you need to make sure that there's no trauma from these maxillary incisors on the gingiva or from that third incisor on the canine. We see it all the time in boxers. And because it's normal, no one worries about treating it. It needs to be treated. If you're seeing trauma, those teeth should be extracted or at least reduced and treated with a bonded sealant. But if there's no trauma, there's no treatment. But if you see it in a puppy, this is a situation where you got your lower incisors out in front of your upper. And if this dog is genetically programmed to have a normal bite, he can't because these incisors are going to hit. Again, that's an adverse dental interlock. So we need to relieve that. How do we do that? Pull the puppy teeth out. When? Now. As soon as you get this out, it'll start to grow. It won't necessarily grow. This would have a much lower prognosis of fixing, but there is a chance. If you don't pull the teeth, it's not going to do anything. So what teeth would I take out? I take out all of these incisors. I know some textbooks say to take the teeth out on the jaw that you want to move. I take them all out, but I wouldn't take these out over here because you can see that this is in good occlusion over here, but I would get rid of all of these. This leads us into the second theme that's going to go through this lecture. Oh, and the next 2, as a matter of fact. This is a situation where this dog, if you were to extract these puppy teeth, you've got to take an x-ray. You have to. And yes, I know they're just puppy teeth. And yes, I know that you need to take them out. But you don't know what lies beneath. And until you do, you can get into lots of trouble. So let's pretend that Monday or tomorrow, wherever, what day or day of the week you guys are watching this, you pull all 6 of those upper incisors. I told you only had to take 4, but you took all 6. So let's pretend that this dog is this dog I'm going to show you now. Okay? So this is a 9-month-old show dog. You can see how wide the pulp chambers are of these canines. This is a young dog, about 9 months old. And it's a $1 million show dog. And the breeder, shower client, came to me and they wanted me to pull these third incisors. Okay? Because you can see those are deciduous teeth. And these are the adult ones. And they're like, well, if you pull the puppy teeth, the adult teeth are going to grow in. Do you guys see anything wrong with that? Any issues with that? Yeah, there are no adult third incisors. Not a problem for the dog. They're perfectly happy with puppy teeth being there. But it is a problem for the show people. But let's just pretend that this is this dog here, going back to, 10 weeks of age. And you go in and you extract all 6 of these upper incisors. Well, how many adult incisors are going to grow in? 4. And whose fault is that? It's yours. Well, because it's obvious that you pulled the adult teeth when you were only supposed to be pulling the puppy teeth. Yeah, we know that's not possible, but you know, there's these things out there. You might have heard of them. They're called lawyers. Yeah, I've been the expert witness in a case of this. Please take dental x-rays before you take out any tooth. Trust me, it'll save your bacon sometimes. Okay. Class 2 malocclusion is where the upper jaw is longer than the lower jaw. Now you've got this lower canine coming in and punching up into the palate here. So this is a severe case of it. This is a Doberman. He's about 9 weeks of age. And you can see the deciduous teeth here. And I think he broke off a deciduous tooth there or something like that. But he's a youngish dog. And the client, brought it to me for a second opinion because his first doctor said actually put him to sleep. He's never going to be able to eat. And the dog was eating fine. But we pulled this tooth and pulled the puppy teeth up in here. And guess what? The dog grew out to be a normal bite. He's like, oh, it's a show dog. And I laughed, to myself. And he's like, but doc, this is a show dog. And I'm like, I don't think you have a show dog there, but let's pull these teeth, make them comfortable. And it grew out to be that Doberman I showed you before. So interceptive orthodontics can work. I tell people, well, this is like that infomercial you watched at 3 o'clock in the morning. Your results may vary. Yeah, don't expect it to work. But it did in this dog. But regardless, we got him comfortable. Same thing here. Look at this poor dog. Punching up into his palate. Huge amounts of pain and inflammation. Pull those puppy teeth right now. Get them out as soon as you can, gets them more comfortable, and allows the jaw to grow. I'll tell you, this one probably won't self-correct. It might, but it probably won't. And if it doesn't, it's going to look like this. So this is a class 2 malocclusion in the adult dentition. And now you got this lower canine trapped on the inside of this upper canine. There are veterinary dentists that do orthodontics on these teeth. I wouldn't. I would strongly recommend against it because moving those teeth around and trying to get around is just miserable. There's no room. It's supposed to be up here. There's no room. So if I was treating this case, I would do what's called coronal amputation and vital pulp therapy. So we cut the tooth off and it's kind of a fancy filling, that's about it. And it works out quite well. And in our hands, it's got really, really, really good success. If you don't have a vet dentist in your area, extracting it is certainly reasonable, but this is way better for the patient. It doesn't hurt much. Not near like an extraction. Keeps the tongue in the mouth usually, keeps the strength in the jaw. The dog still has, some of his teeth to work, and it just hurts a lot less. Okay. So that's orthodontic issues. So now let's talk about a similar situation, and that's persistent deciduous teeth. Yeah, you can call it retained deciduous, retained puppy teeth, whatever you want to call it. But the current terminology is persistent deciduous. This is where the adult teeth are coming in alongside the puppy tooth. And there's a couple issues that happen. Number one, as you can see, these lower canines are coming in on the inside, and that is now creating an orthodontic problem. So the orthodontic problems start in 2 weeks after the adult tooth starts to erupt. Not once it's in, once it starts to come in. So here's the thing. The adult tooth does not need to be fully erupted for the puppy tooth to be considered retained. As soon as this adult tooth starts to erupt, there's no impetus for the resorption of this puppy tooth, and it's not coming out on its own. So in the human literature, they talk about enamel touching enamel. So as soon as this crown breaks the surface of the gum, it's considered retained, the puppy tooth is, and it needs to be extracted now. Because if you don't, you're going to end up with an orthodontic problem you have to treat. But more of a problem is the periodontal health. As this adult tooth erupts, it's supposed to mature the periodontal attachment with the erupting, or the gingiva, along with the erupting adult tooth. Well, the issue is on the outside of this lower canine, and on the back side of this upper canine, it's not attached to the adult tooth because it's attached by the puppy tooth. Studies have shown that if you leave this puppy tooth in for just 2 days after the adult tooth starts to erupt, not once it's in, once it starts to come in, you've already set this dog up for irreversible periodontal disease. So you can see how much gingival inflammation in this 9-month-old dog we already have. And then this dog here is about 10 months old. And you can see he's got a 10-millimeter pocket. At 10 months, he's getting ready to lose this lower canine. Okay? So we need to get these puppy teeth out now. Not waiting until 6 months till they're being spayed or neutered. Not watching them and letting them fall out on their own. You got to get them out right away. That's going to make your animals healthier. Okay? These are real teeth. This is your client's perception of a puppy tooth. This is your reality of a puppy tooth. You absolutely need to have these when you get them out, put them in bleach overnight, put them in your drawer in your exam room when the clients are allowed back into the exam room, and show it to them. And I'm telling you what, your clients will go, ugh, I had no idea it was that big. Of course not. Not their job to know. Your job is to educate them. Keep these. That will allow you to charge appropriately as well as give pain management because your clients think it's just a puppy tooth. It's not. It's a big tooth. I'm telling you what, that dog, a small breed dog, even a Chihuahua, the root is longer than a cat's canine is. Would you ever consider charging $25 to take out a cat canine? Would you ever consider sending home a cat, after extraction of his upper canines without pain management? I hope the answer is no. Give these dogs drugs, charge appropriately. The other thing about these are, you need dental x-ray. Yep, I told you, every single time I'm going to give you a reason why, and if you're fighting it, stop, do it, join the team. So what's supposed to happen with a retained or with a deciduous tooth is that the adult tooth is supposed to come right up underneath the puppy tooth, like here on the second premolar. And it causes the root to be resorbed, and then it takes its place because there's no root left. With retained deciduous teeth, the adult tooth comes in alongside the puppy tooth, not right up underneath. So what happened is the tooth came along, and oh, by the way, for those breeders who want to blame the malocclusion because of the retained deciduous tooth, it's actually the other way. The malocclusion caused the retained deciduous tooth, not the retained deciduous tooth caused the malocclusion. So the adult tooth did not come in the right place, so it didn't put pressure on the apex of the puppy tooth and did not cause it to be resorbed. So unfortunately, this root is normal. But why do these blankety blank things always break? Well, number one, they're longer, they're thinner than permanent teeth. But the thing is, can you see this little divot here? This is right at the gum line. So as the adult tooth came in, it put pressure right here on the tooth, caused it to be resorbed. Okay? So as soon as you take your elevator here, you're going to snap it off, and then you have to do the cursing dance. Okay? And then you must, yes, must dig it out. You have to curse it, make a flap, take the bone away, and get it out. Why? Despite popular belief, despite what you were told, despite what you want to hear, despite what you want to know, despite the fact that you get away with it, which is what I've heard from many vets, your patient does not. And these teeth do not resorb. They don't. Absolutely plain and simple. They just don't. I've taken so many infected deciduous teeth out of 12, 14-year-old animals. They're there. So if you take an x-ray and it looks like this, you got to get the whole root out. So I would take a 1 millimeter. I don't do these surgically. I use a 1, maybe 2 millimeter elevator at the biggest, or a 22 gauge needle. Get it down here, small sharp instruments, get down below that defect, and then you're going to get it out intact. Okay? If it breaks, you have to go after it. But vice versa, the reason you need an x-ray is it might look like this. There's nothing left. This is happy dance time. There's no root left. Pluck it out and you're done. But if you don't have x-ray, you might have gone digging after a root that doesn't exist, or you might have broken off and go, oh, it's all resorbed. And it's not. Got to have x-ray. Please, please, please. Pre and post. Post, don't forget. Got to take post-op x-rays. We'll talk about that later more. Supernumerary teeth. Similar to retained deciduous. You got 1, 2, 3, 3, 4. Okay, so this is a supernumerary third premolar. This is a big dog. He's got room. See, there's room in these teeth. There's a touch of crowding there, but not a big deal. I wouldn't do anything about it. But when you start looking at something like this, you can look over here on this other side. You can see that fourth premolar. This dog has got bilateral supernumerary upper fourth premolars. And we knew about it, or the vet knew about it at about 8, 9 months of age. But they didn't recommend any therapy because, right, it wasn't bothering the dog. Well, this is a 4-year-old Dobie. How often do 4-year-old Dobermans get horrible gum disease? Yeah, not. Why did that happen? Because of the crowding. Now you can see all this recession, all of this pus. This is bilateral, by the way. They're horribly infected. The dog's breath was rank. And when you take an x-ray, you can see the bone's supposed to be here. The bone's all the way down here. This poor dog suffered with this for the last 4 years, had horrible infection, then I had to come back and extract all 4 carnassial teeth, gee, that was fun, and create this huge flap to close this defect. It all could have been avoided by extracting these supernumerary teeth young. So when you see supernumerary teeth causing crowding, and you'll see this also in your brachycephalus, your maxillary, the jaw of the brachycephalus. When they have that crowding, especially when the distal root of the third premolar is in the mesial roots of the upper fourth, take out that third premolar. Selective extractions will make your patients healthier. All right, fractured teeth. 10% of all dogs have a fractured tooth in their mouth with direct pulp exposure. 10%, that's a lot of them. A lot of them have uncomplicated crown fractures too. The problem is, and I hear this all the time and it drives me crazy, doesn't bother him, doc. He's eating. I hear it from vets. Let's watch that. Watch it do what? Rot out of his face? Really? No. Here's the thing. Fractured teeth hurt. That's an exposed nerve. This dog is in agony. It won't show it, but he's in agony. So here's the story with fractured teeth. Fractured teeth are either incredibly painful, or here's what happens if you don't treat it. So here's an older fracture. Now look on the inside. That pulp chamber is hugely necrotic. It's got three root canals that are all bacterial superhighways, taking the bacteria from the mouth through the root canal into the bone and off to the body. So here's the thing with fractured teeth. They are either horrifically painful, incredibly infected, or both. And there's only two options for therapy, and that's root canal therapy or extraction. That's it. You can't watch it. Watching it's got to do nothing other than make the dog suffer. Because you don't want this black stuff coming out of your mouth. The dog doesn't want it in there. Occasionally, and this takes a while, honestly, this takes years usually, the dog will finally abscess. He's been suffering for years, but the abscess got pus pouring out his face and swelling and angioedema. But this dog's been miserable for a long time. And unfortunately, a lot of times we'll see it, and this tooth has been broken forever. This dog had a dentistry that said broken tooth, didn't recommend any therapy. Why? The vet didn't want to pull an upper fourth. We can fix it nowadays. So here's what the x-ray looked like. That's where the bone's supposed to be. That's where the bone is. It's all gone. You can't tell me that this didn't hurt. It absolutely negatively affected the dog. We pulled that tooth, and guess what? Client called back 2 weeks later going, he's a whole new dog. Of course he is, because you took him out of pain and you took him out of infection. So please remember, every tooth with direct pulp exposure, just so you can see, anything that looks like that, or black like that, root canal therapy or extraction. Okay. Now, a similar lesion, but not as severe, is what's called an uncomplicated crown fracture. That doesn't mean that there's no complications. It just means that it's not directly into the root canal. This means that the dentin is directly exposed, but not the pulp. So the shiny area out here is the enamel. That's our pearly whites. It's the hardest substance in the body. Okay? It's a rock, basically. It has no sensory ability, no ability to regenerate. It's only formed before the tooth erupts. We'll talk about that a little bit more in a minute. But it's impervious, basically. The dentin, everyone thinks of as a solid structure. It's not. The dentin is a living structure, and it's porous. It's got millions of dentinal tubules running out at right angles from the root canal out to the periphery where it's covered over by enamel. So the problem is, when you expose the dentin, here's the thing, indirectly expose the root canal. So the root canal is exposed, just through like a screen door. That's how I describe it. The enamel is a solid door. The dentin is a screen door. Protects you from a lot of things. Bugs, sometimes, some of the animals won't come in, but noxious gas is going to get in there. Bacteria is going to get in there, right? So you need to treat this. This is painful. If you've ever had a sensitive tooth from a deep cavity, you know this hurts. So you need to treat it. Okay, how do we treat an uncomplicated crown fracture? Well, depends on the x-ray. Exactly. So here's the same dog. Okay, it's the opposite side. So these teeth pretty much look exactly the same, right? Dentin exposure, minimal amount, looks really good, right? Well, here's one x-ray. Okay, so this is the right side. And what you can see, normal periodontal ligament, normal root canals, everything looks great. This tooth, as far as we can tell, is vital. It looks fine. So if I saw this x-ray on this tooth, I would do a procedure called a bonded sealant. Bonded sealants are very minor restorations. They basically smooth out the tooth to decrease gum disease, blocks out the pathway for sensitivity, and blocks out the pathway for infection. To get into doing bonded sealants, if you have a drill system and an x-ray, and if you don't, we need to talk. But if you have a drill system and an x-ray, to get into doing bonded sealants costs about $600. That's it. That's a bonded sealant kit and a light curing gun. Again, it's on Dog Beach Vet. It's on our website, also through Dental there. You can get the components anywhere though, but they have an actual kit. It's $600 will treat 40 teeth. So it's about $12 a tooth at the beginning, and it takes about 2 minutes. After that, you don't have to have the light curing gun anymore. All you need to have is the bonded sealant kit, which drops your price to about $5 a tooth. And you could easily charge $50 for this, and the dogs feel better, trust me. So if you see an uncomplicated crown fracture, you need to x-ray it. The x-ray is normal, bonded sealant. And oh, by the way, we teach that in our level 2. We also have a book on it if you guys want to do it, from home. But if you see this periapical lucency means that tooth is infected. Can't do a bonded sealant on it. You go back to root canal therapy or extraction, plain and simple. And again, we just finished a study with one of Dr. Carmichael's residents. It's about 18% of these teeth are infected. So x-ray them all, please. Get them out of pain and infection. Worn teeth. We don't see them as often as we used to, thanks to program advantage, things like that. I'm dating myself. How about CapStar and different things like that? I don't know. But I don't treat dermatology anymore, thank God. But this is a dog that's been chewing on his rear end for a long time. So these are worn teeth. And if you see pink like that, or brown like that, blackness, that's pulp exposure. You can get a probe to go in there. And if it's pulp exposure, again, root canal or extraction, obviously we're going to extract these teeth because we're down to the gum line. But if you see tan like this is not pulp exposure. This is what's called reparative dentin. As the body wore down, or as the dog wore down the teeth, the body responded by reseeding the root canal and laying down reparative dentin. The reparative dentin, or tertiary dentin, is not as organized as standards, what we call secondary dentin is, and so it picks up stain faster. So you're seeing stain on that, what used to be the root canal. So I would definitely get this dog down and I would probe him. If it's solid, you take an x-ray, and if the x-ray is normal, I don't do anything. You could put a bonded sealant on it, but honestly, there's several reasons why I don't. I'm not going to go into it, but I'm not going to tell you why that you're wrong too. I just don't. But you've got to x-ray them, because here's a dog, wore his teeth down, has dentinal exposure, but no pulp exposure, has good reparative dentin, take an x-ray, big periapical lucencies. So you absolutely, positively need to x-ray these. And again, root canal or extraction. I haven't root canal these because that really wants to break down there trying to take it out. Oh, by the way, don't let anyone tell you you can't root canal a tooth with periapical lucency. You absolutely can. I do it all the time. They do great. There's slightly worse prognosis, but they really, really, really do well. Discolored teeth, purple, yellow, gray, potato colored. They're all dead. Every single one is dead. If it's just the tip, like if it was opposite this and this was purple and this was normal, I would transilluminate it and I would x-ray it. And if those were normal, I would say, well, just the tip of it died. But if that whole tooth is purple, yellow, gray, they're dead and they need to be treated. How do they get treated? Again, broken record, root canal or extraction. Lower canines, I would definitely root canal. What they used to do is x-ray them. So here's an x-ray of an upper canine. Big wide canal compared to the teeth around it, so it's dead. Periapical lucency, we're like, okay, that one's dead. But what they used to do, is before my time, is they would x-ray them, and if the x-rays were normal, they'd say, well, he must have recovered, the tooth's okay. Well, that was until Fraser Hale did a study, and it was published almost 20 years ago. And what he found was that only 40% of these discolored teeth have radiographic signs of endodontic disease, but 93% were dead and infected. So it takes a long time for these radiographic changes to show up in these dogs. So they're dead and painful, and they're dealing with it for a long time before that. So number one, I'd rather over-treat 7 teeth than under-treat, 53%. And also, in my time, since this study came out, I've treated thousands of discolored teeth. I haven't found a living one yet. They're all dead, in my opinion. And again, I think Fraser had some of the tip discoloration in there. I'm not 100% sure. But bottom line is, you see that purple tooth, root canal or extraction. Enamel hypocalcification. This is not distemper, by the way. This is only on these 2 teeth here. So that's not going to be distemper. It's very rarely distemper. Distemper would cause one strip. It's called Turner's hypoplasia. It would be one strip all the way across all these teeth. So for me, this is not distemper. If it's only on one spot, like this is 2 teeth, this is some kind of local trauma, probably due to a veterinarian trying to take out puppy teeth is what I would assume, and they damage the forming enamel. And so the enamel flakes off, you're left with the underlying dentin. Again, you're getting that stain because it's porous. This is painful. It can get infected pretty rarely. It's ugly. It's a little bit weaker, and it's rough. So that's going to worsen gum disease. I'll show you a picture of that in a minute. So we do want to treat this as well because this is really painful. So how do we treat it? Well, in major defects like that, I would do something called a composite restoration. This is a white filling, just like if you guys went to the dentist and had a filling done. I love doing this. It's my artistic outlet. I mean, you take something that looks like this and it looks like this. It's great for Facebook. Works really well for the patient. For the entire mouth, and again, this is the entire mouth everywhere. So this isn't just, an infection that happened at one point. This is what's called ameliogenesis imperfecta. And it's just an ectodermal issue, and it just didn't form correctly, and it all flaked off. And this is a 10-month-old dog. And you can see how dirty the teeth are and how much inflammation we have already. So for this situation, again, you want to treat it for gum disease and for overall health and for getting rid of sensitivity. So for this, if this is the whole mouth, I generally just go back, I go back and do bonded sealants. So here's pre-op and there's post-op. And we smooth it out, get rid of the sensitivity, get rid of the pain, get rid of the pathway for infection, and smooth it out to decrease gum disease. Again, y'all can learn how to do this. We'll teach it probably in March. It's something that's pretty easy to get into. All right, missing teeth. No tooth, no problem, right? Not necessarily. There are 4 possibilities for missing teeth. Okay? Number 1, they were born without them. Okay, that's fine. Number 2, previously extracted or exfoliated. Okay, that's fine. Number 3, okay, and the most common, to be honest, broken off with retained roots, either naturally or somebody trying to take the tooth out. So here it is. Okay, see that right there? Big periapical lucency. Look at how much infection there is here. Dog had no clinical signs. Absolutely none. So you got to x-ray every missing tooth. Now, if you extracted this tooth 2 years ago and you took a post-op, and there was nothing there, then there's not going to be anything there. So, but if you don't have a post-op that you extracted it or something from last year, x-ray every missing tooth. And the other possibility is what's called an impacted or embedded tooth. Incredibly common in brachycephalic dogs, the pugs, the boxers, the bulldogs, especially Shih Tzus and Lhasas. Really common for them to be missing, quote unquote, their lower first premolar. And they have this thick, what we call operculum. It's this gingiva in this area is really thick in brachycephalics, and the tooth can't grow in. And about half the time when they're, quote unquote, missing them, they're actually there. So here it is, sitting up underneath the gum. So the gum's sitting right here. And because of that thick operculum, it couldn't grow in. So what happened is it grew to the side. And like I told you, the enamel is only formed before the tooth erupts. It's formed by what's called an enamel-forming organ. The enamel-forming organ are amelioblasts. And the amelioblasts line the crown of the tooth. And what happens when the tooth erupts into the mouth, the chewing action wears it away. Well, the problem is that in this situation, that tooth didn't erupt. So that enamel-forming organ or amelioblast did not get worn away, so they stay there. And a certain percentage of the time, if you read Dr. Luskin's study, 29% of impacted teeth will develop dentigerous cysts in dogs. So if you see one, especially in a young dog, you need to get it out. And especially if you see this little black area, that's the dentigerous cyst forming. It's a very early one. If you take an x-ray young and you see a small dentigerous cyst, y'all can handle this case. This isn't that scary. You make an incision over it, you pluck it out. I mean, it's just sitting underneath the gum. I would do an envelope flap, okay? Just make an incision between the canine and the P2, lay the flap back. It's very thick, so it's hard to get through, but it's not a hard flap. Once you're through, it's just sitting there, pop it out, take an elevator or a curette, scrape the heck out of that lining, 2 stitches, 3 stitches, you're done, 10 minutes, piece of cake. The problem is if we don't take x-rays early enough, which is why we recommend that all dogs get all full mouth x-rays and an exam and dentistry by 2 years of age if they're large, if under a year of age if they're small. We'll talk about that with perio. Because the problem is if you don't, it could end up looking like this. So now we've got this lower first molar that's impacted, creating this huge cyst that goes all the way from I1 to P4, pushing all the teeth back, almost breaking the jaw down here. Huge amount of surgery to get this out. Thank God we found it now. We have to take everything from I1 to P4, and yes, it's running down into the mandibular canal, which is really fun. You have to meticulously scrape out this lining. I would probably put some bone augmentation in here. I don't often do that, but that's a huge defect. So now it's become a huge surgery because we didn't take care of it when it was younger. And oh, by the way, there's no clinical signs. This was found on routine prophy. So what we've seen we've seen, not a lot, but we've seen jaw fractures, and it's pathologic fracture just like perio is. All right. One of the last things we're going to talk about is cancer. The oral cavity is the fourth most common place to find cancer. And the challenge is that it can be everything from super benign to incredibly malignant, and they all look pretty much the same externally, especially at the beginning. So I'm going to take you through the different types, and I'll take you through the different prognoses and treatments. So this here is a peripheral odontogenic fibroma. Okay, so it's a wart, basically. It's a hamartoma. It's totally benign. So if you see this, and it's very firm, and it's growing out, not in. Okay, you see it's not invading, it's growing out. If you see this, I would take an x-ray. The x-ray is normal, so this is what we're looking for. This is happy dance time. There's no evidence of any bony reaction. So in this situation, I would cut it off to physiologic margins and biopsy it. If it comes back as benign, as a fibroma, I would monitor it. If the client really wants it out, you have to take the tooth it's coming from, and unfortunately you have to sacrifice this upper fourth. But if I monitor it, if it grows back quickly, we can take the tooth out. If it grows back, and do a marginal excision. If it grows back slowly, just cut it back every year. And just trim it. It's not a big deal. Okay? Even these big guys, I mean, this looks really scary. It's an ossifying fibroma. Totally nothing. Cut the stalk off, see what it is, make sure it's not a cancer. If it grows back, you can always take the teeth out later. But when you start seeing this ulceration, that to me is a sign that it's probably more aggressive. And could the dog just damage it? Sure. But it's usually this ulcerative appearance is going to be more aggressive, and especially when you start seeing the bone and tooth being eaten away. This is your sign that it's all likelihood it is a more aggressive cancer. The next level up in aggressiveness is what's called an acanthomatous ameloblastoma, used to be called an acanthomatous epulus, or a plasma cell tumor is very similar. So you can see the swelling here, okay? And this dog had a tooth extracted because it was loose. Well, here's what this dog looks like. So you're looking end on a tooth there. This tooth's been pushed out of the side. This is what I would call a benign-ish tumor. That's a Brookism. Benign-ish means that it's not truly benign because it is invading bone, but it doesn't spread. So the nice thing about acanthomatous and plasma cell tumors is that they grow by expansion, kind of like a cyst, and they push things out of the way, and they tell you kind of where they're at. You can see like a little transition zone because this is a two-dimensional image of a three-dimensional space. But it's not invading. So the nice thing about acanthomatous and plasma cell tumors is that they kind of tell you where you're at. And so if you're going to treat them, you only have to take a 0.5 to 1 centimeter margin. And I've never had one grow back that the clients let me do an aggressive surgery on. It works quite well. Radiation therapy will essentially cure plasma cell tumors and control, for the most part, acanthomatous if the client is not interested in aggressive surgery. Speaking of aggressive surgery, this is a fibrosarcoma in a dog. It looks very much like a squame as well. These are very aggressive locally. They can spread, especially if they're more distal in the mouth, or caudal in the mouth. They can spread, but they typically don't. But they're incredibly aggressive locally. They invade the bone quickly. They send out microtendrils. So the treatment for squamous cell carcinomas or fibrosarcomas is everything you can see clinically and radiographically, plus 2 to 3 centimeters of margin. That's a lot of surgery. So unless you catch it early and you get it forward in the mouth, then it's really hard. As far as radiation therapy, it does help these. Not in cats, we'll talk about that. But in dogs, it does. It usually buys them about a year, so that's not too bad. And if the client if we can't do surgery, and a lot of times, unfortunately, by the time we see it, it's too far gone. So this is really where you need to have your clients brushing their animal's teeth, because that way they're looking in their animal's mouth. You should really be talking to your clients about doing oral exams, because that way we can save a life. And speaking of bad cancers, this is melanoma. Melanoma is the big baddie. It's the most common malignancy in the mouth of a dog. Not only is it locally aggressive, it spreads like wildfire. 90% of the time, by the time you've diagnosed this, it's already spread. It's already someplace else. So unfortunately, these dogs usually expire because of their spread, not because of their local disease. But biopsy it, and you can treat it. I mean, if we can cut it all out, that's ideal. But usually they've already spread. So I don't generally put these dogs through a radical surgery. I'll generally debulk it and go with radiation and chemotherapy. Plus or minus, there's a vaccine that's supposed to be fairly effective as well. Again, that's an oncologist question. We're not even allowed to get the vaccine, at least as far as I know from last check. So it's only available through oncologists, which is fine. But some oncologists still like chemo. Other ones like the vaccine. I would just trust whatever your oncologist likes to say, because I don't know much about that. I'm more of a surgeon. So speaking, and oh, by the way, those dogs with melanoma, typically you can get a year, a good quality year, unless it's too far gone. But that's chemotherapy, radiation therapy, surgery, and plus or minus the vaccine. So it's a big chunk of change and a lot of work, but you can buy some good quality time. But speaking of aggressive surgeries, a lot of clients are, hesitant to do a mandibulectomy or maxillectomy on their dog. And I get that. It's kind of like an amputation. But dogs do great with amputations. They really do. And a lot of these, if they've got a good prognosis, I'm a big believer in doing this surgery. So I think clients need to be educated. So I'm just going to show you what these animals can look like. So this is an acanthomatous ameloblastoma. You can see it kind of growing down the lip here. So it was invading down into the canine teeth there. So we had to do a pretty aggressive rostral mandibulectomy. So we went back to P2. So that's a pretty big chunk out of this dog's jaw. And then you would think that he would be unhappy for a while. Yeah, you would think. He's a dog, right? 2-week recheck. Here he is. Could not care less. Got a little drool coming out there. Playing ball, eating, drinking. Took about 72 hours to kind of go, what's going on with my face? All right, it's time to eat. So, imagine if you lost a couple fingers. It would be bad, but you deal. You do it. And the dogs don't care. They really don't. So, oh, by the way, this information and everything we talked about is on our website, dogbeachvet.com, dogbeachvet.com, really easy. I have client educational videos that I shot several years ago. So some of the knowledge may be dated, but it's professional videos with pictures and x-rays of all the pathology we talked about, including periodontal disease, periodontal therapy, jaw fractures, cancer, stomatitis in cats. It's all on there. If you don't want to spend a lot of time talking to your clients, or, again, with COVID, if COVID's still going on when you guys are watching this, you got to worry about, meeting face-to-face and having that long discussion with clients. Send them to our website. It's a great education for them. And so the last couple of things I want to talk to you about, we'll finish up this lecture. Just because it looks evil doesn't mean it is. This dog, that's my finger there. This dog's got a massive mass in his jaw. And I was like, oh, it's got this huge cancer. Your dog's going to die, blah, 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 blah. Well, we got him under. He had a foreign body. That was all foreign body reaction. It was all granulomatous. Looked evil. Looked like a death sentence. Pluck that out. A little bit of surgery. Cured him. Just because it looks bad doesn't mean it is. Vice versa. What's that? Little hyperplasia, right? A little bit of fibroma, right? That's a melanoma. This is a client's dog from many years ago when I was in general practice. And I found it and I biopsied it. And it came back as melanoma. Yes, I questioned it. And they said, yep, it's definitely an early melanoma. So I did a partial maxillectomy. I think I went from I1 to the canine. I was somewhat aggressive. Got it out. That was all we did. Dog lived for 7 years. The only thing that really effectively treats oral cancer is early aggressive surgery. The sooner you find it, the smaller the surgery is, the less chance it has of that. That's why you need to get your clients to look in the mouth, but also biopsy everything you see. Anecdotally, again, 1% of those benign-looking lesions will be malignant. And in 25 years of doing it, God, I'm getting old, 25 years of being a veterinarian, I've been doing this. I will tell you that I biopsy something that looks like that at least once a day, sometimes 2 or 3 times a day. And I will say in my experience, a couple times a year, we're getting these things, oh, I thought it was nothing. Yeah, it's a bad cancer or an acanthomatous or something that needs to be treated. In all those years, I have never had one client that when I biopsied it and they called them, what I tell them, I said, you know what, 99% plus, this is nothing. But if it's that 1%, we're going to find out about it now and we can cure your dog and everything will be great. We can't watch it in the mouth. If we don't do anything about it today, and it is one of those 1%, you're rolling the dice, right? You like to go to Vegas? You're rolling the dice. If it's not, which is, highly likely, then great. If it is, the dog is going to die from it probably because we can't watch it. So I just recommend nicking it off and biopsying it. And I've had a couple clients decline it because they're like, you know what, doc, even if it is cancer, I'm not doing anything. Fair, I get that. But 98, 99% of clients are totally fine with it. And again, I do have really good clients, but at least recommend it. And I've never, like I said, ever had a client, because I'll tell them 1% chance is bad. I want to be realistic, but I've never had a client ever that said, well, then why did you waste my money? When I called them back a week later with the results, they've all thanked me for being so thorough. So please, 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 please biopsy everything. So the June 8th to 9th may not be accurate. We are planning next year in doing hands-on labs again. This is generally February, June, and August is when we do them, and that's what we teach. So all that information will be on dogbeachvet.com. I hope you enjoyed the lecture. That's everything you can find about oral pathology in a dog. And signing off from San Diego.